Good afternoon all. Thank you, Mr. Chairman, Co-Chairman and the organizers for giving me a chance. In fact, the topic, my topic will be a little bit overlap because he himself told that isolated depressed fracture like this falls in type 3 fractures and some of the recent literature shows. So it can be either a central or peripheral depression fracture of the lateral plateau from minimal impact on a weak bone. The stability of the joint is rarely affected. If excellent function, minimal joint congruity can be obtained in many cases, and majority may be treated by conservative methods. And the depression of the fragment depends upon the flexion angle of the knee at the time of injury. At the time of the injury, if it is an extension, it will be about 6 millimeters, and in flexion it can go up to 30 millimeters or even more. In a recent paper by Gar and colleagues, they have shown one note of MRI in type 3 fractures and proved that there is no pure depression fracture in type 3. Almost all had a peripheral split. So take care in conserving them so many of them can go for a late collapse. And 3D CT is a must to find out the depth and location of the depressed fragment as either anterior, middle or posterior. And most important thing is not the 3D CT, you get a 3D CT in your own mind. So you are going to do a navigation of the fragment to come out. So our own mind, we must, our hand, if your brain knows that your hand automatically will go there and elevate it. And look for any peripheral split like this. You can use that as a window to elevate the fracture up. And CT has changed the decisions of classification change of 12% and treatment line has changed in 26% and treatment plan has been modified in about 60% of the cases. The aim of the treatment is to get a painless, stable, mobile joint, and the key is good articular reconstruction and more than that, a good axial alignment. How much is the depression which can be accepted? There is no universal agreement. Generally up to 5 millimeter may be okay. The most important thing is that depressed fragment cannot be elevated by traction. It always needs surgery. A well-aligned knee can tolerate up to 5 millimeter depression. Avoid axial malalignment to prevent secondary osteoarthritis. I think ring fixator is the best to get it because you can play with it in the postoperative period to maintain the alignment. And there may be so many problems like late collapse. Depression of 4 mm can happen in about 14%, valgus instability. And if you open it up, there is a chance of avascular necrosis of the fragments. And weight bearing has to be delayed till bony healing when you do buttress plating, but not in Ilizoro. When you span the Ilizoro, when you do Ilizoro, your patient can walk early and they can even span the knee joint when there is a soft tissue element. And we have so many types of treatment modalities available. Percutaneous screw, which has been mentioned by Gag, and rafting screws with support screw, without support screw, lateral buttress plate, and ring fixations. And the most important thing which you all must know, fracture is definition of a fracture. Fracture is a soft tissue injury, is complicated by a broken bone. So we change our most important thing, especially upper and tibia. It's a soft tissue injury rather than a bony injury. And earlier surgery is definitely useful, but in a compromised soft tissue envelope is a contraindication for early ORIF. So it is not a contraindication for a closed reduction and ring fixation. So when a bone is stabilized, the soft tissue get earlier healing. Look at this patient who had a runover injury. He had a depressed lateral condyle fracture there, and you can see a Hoffa fracture and you can see a lateral malleolar fracture. So all these things along with the compartment syndrome, with the opposite side patella is for a non-union. And the only limb which is affecting, and that's in compartment syndrome with the lateral condyle fracture, lateral Hoffa fracture, and the lateral malleolar fracture. I do an immediate emergency open fasciotomy. At the same time, I just elevated the lateral fragment, put a ring fixator on that, spanned the knee joint because there's a Hoffa, and hook the fragment of the lateral malleolus. Everything there. No, I have not opened the fracture site, and that is the result in about 2.5 months' time. And he is working on that. The third day he is on his feet. 7th day he got discharged, and that is the function in 2.5 to 3 months' time. So a depressed fragment may be locked sometimes. You can see here, the depressed fragment has gone down. So the initial thing which happened is the lateral split. And then the fragment goes down, and the split comes back, and it's actually locked. So when you have to use a very big instrument for elevating it. If you find it's very difficult to come, you can unlock it. So unlock the fragment, disimpact it, and elevate it en masse from below, either through the window or through another opening down there. And I don't like the thick instruments, I like blunt cavers as a joystick, either through the split or submetaphyseal cortical entry, and you don't have to do any bone grafting there. You can just elevate it like this, and avoid using thick implants like this. If you use a thick impactors, it produces a big void there, that void has to be filled. And you know the upper end of tibia will eat bone graft like anything. Even if you do bone cement, it will eat bone cement like anything. And if there is any lateral displacement, that has to be corrected by a periarticular clamp after elevation of the depression. Keep in mind that the status of the lateral meniscus. Many a time, the peripheral tear of the lateral meniscus can go into the depression, that has to be elevated. And protect the elevated fragment by subchondral cluster of the cavities and the concept of raft fixation. If you raft it properly and plate it well, then you don't have to do any of the bone grafting, because the peripheral healing is the most important part for, if the periphery is healed well, it will never go for a re-depression. If you are not happy with the cause, ring fixation is an excellent tool for maintaining articular and metaphyseal reduction in a minimally invasive mode with an option to correct the alignment in the post-operative period. It has significantly reduced the rate of wound necrosis compared with extensive ORIF. It has a risk of intact infection. Look at this little complicated depressed fragment there. Posteriorly, it's in two pieces, and you can see that depression there. And this can be elevated like this, and multiple small olea wires. Patient is on her feet in 3 days time, no sutures area.